ahead.
So following knee injury and or surgery, you can have an arthrogenic inhibition of the quadriceps, where it is difficulty to activate the muscle volitionally and or reflexively.
So when you
Notice the
come
slight
up,
knee lag
pull the toe
that the patient has,
towards you.
even
Yep,
despite
come
the
up, pause,
artificial
and try and time
stimulation
the
due to
descent
NMES
with the
that the
stim.
patient is
Meaning by the
utilizing
time the stim
with the
cuts
straight
off,
leg
you're
raise.
already down.
You'll notice the slight discrepancy, particularly at the bottom where she disengages, and then as she tries to re-engage, she'll get a co-contraction in the hamstrings as well as the quadriceps when trying to lift.
You always know when you go too high.
Yep.
One thing that I was not aware of is the contribution of the adjacent joints and the altered afferent information that those joints can have on the quadricep activation. So this is a clinical lesson that I learned. So let's take a look at her ankle. So on the right side, her right side, so that's the left image, you can see her performing a straight leg raise. Okay. Notice not here so much, but when she comes down, notice the angle of the dorsiflexion. So she's got this perfectly pure and slightly even everted orientation of her foot as she maximally dorsiflexes to help to recruit the quadriceps and the anterior chain muscles. Now watch on the involved. So she never gets to neutral, nor does she evert at the ankle. Upon assessment, the ankle was limited in dorsiflexion and restricted at the subtalar joint in its eversion. So the intervention that was performed was 3 consecutive long axis distraction HVLAs, or high velocity low amplitude thrusts, which were positive for 3 consecutive cavitations of the ankle. That was the only intervention that was otherwise provided. So then we retested the quadricep activation with the straight leg raise. You'll see this on the coming slide. Okay, so here's pre. Again, notice the slight knee lag and the slight co-contraction that occurs upon the initiation of the movement. And then watch here. So complete relaxation, dorsiflex, where she locks this out, and then the whole thing rises. Versus in video 1, despite the dorsiflexion that she gets, she does not get the active straight leg raise, and there's a slight knee lag and co-contraction. The subjective report was that she felt as though her leg was reattached, and that it was so much easier to not only perform the contraction, but the exercise itself. So, clinical lesson of the day: when assisting with quadricep activation, consider the afferent input and joint mobility at the adjacent joints of the muscle and or joint in question. Thanks for listening.